Hello, and welcome to Family Matters, a joint production of the Bowen Center for the Study of the Family and the University of the District of Columbia. I'm Dr. Mariana Martinez, your host. When a family is faced with an unexpected illness or medical emergency, there is a high increase of anxiety that can impact various relationships within the family. Avoiding this anxiety is difficult when, in addition to the expected illness or medical emergency, the family is also engulfed by a complex healthcare system, medical decisions, and unexpected financial obligations. Beatrice Flynn is a clinical nurse, specialist in psychiatric mental health nursing, and a faculty member of the Bowen Center for the Study of the Family. Beatrice has a private practice in Baltimore. Her professional experience includes 20 years of practice in a general hospital where she has been involved with education, crisis intervention, bereavement, and consultation with individuals, families, and staff. Beatrice joins me to share some insights into how Bowen theory provides some useful ways to manage oneself as you navigate the medical system during a family illness or medical emergency. Welcome, Beatrice, to Family Matters.
Thank you.
Well, you're bringing in 20 years of experience, and let me start with a little story. The first time that I joined the Bowen Center or participated in any activity, it was you who was presenting. You were presenting a talk about the medical system and how to go about it. At that very same time, I had a nephew who was going through a very serious medical condition, and he had been in the hospital in and out, and it was a real important event in my family. So hearing what you had to say was very important, and lots of aha moments during that talk. So I'm very happy that you are here to share those thoughts with us today.
Thank you.
What do you think are the challenges that people face when all of a sudden they're in a hospital setting?
Well, there's no shortage of challenges. I am a person who absolutely loves hospitals. I can walk in the door and get an adrenaline rush, and I'm looking for where's the excitement. That's not the way it is but if I was the patient or someone in my family was the patient, I wouldn't be in that place. I would be more on the highly anxious side. So I have really been blessed to work in a position in nursing in a hospital where I could walk beside patients and families who were going through a significant physical illness in themselves or in a family member. I don't even know how one would get through today the way the healthcare system is. It's so fast-paced. There are so many changes. You're in, you're out. I remember the day when people stayed 5-7 days, and maybe they had the same treatment team for the whole 5-7 days. Now people work 12-hour shifts. You may never see that person again. You may never see that doctor or nurse again. So it's just very different, and I think that having an ability to think your way through it is very useful, and that's really what my job was, and Bowen theory guided that.
To help people think through their progress or process of getting better. What sort of things does one have to keep in mind when you're thinking through, how do I face this challenge?
Well, where I start with is with myself, and it's how do I think about this? How do I think about this person? How do I think about what's going on here? Again, I would be in a situation where I would be one of probably the only person thinking from a systems point of view, as opposed to a medical model, cause and effect. This disease is caused by this. This is the treatment, go by. Instead, I stand pretty much alone looking at the person that's in front of me as one of a family, and that the process or the illness that they're dealing with is about the entire family. It's not just about this person. I think that's just critical to how one functions. That really provides a baseline, and everything falls from that. I remember I was very lucky to study with Dr. Bowen myself, and I remember him saying, I'm going to mess up his words a bit, but here's the gist of it. He said, if you ever see a patient in the bed and don't see his entire family standing on his shoulders, you are going to miss the boat. Well, I took that very seriously, and so I began literally imagining people standing on people's shoulders and, you know, just knowing that this was bigger than the person in the bed.
But what difference would that make in the emergency situation, in the medical decisions when you have to decide whether to have surgery or not, or to go through certain treatment or not? What difference does that make?
Well, it gives you a baseline for gathering data, for one thing. And I will remind you that in every family, more than one thing is happening. One person's here in the hospital, but somebody else is home trying to find childcare so they can come see their mother, and somebody else just lost their job, and somebody else has something else happening. There's 2 or 3 sick people. Quite often, what you will see is one spouse sick in the hospital, for example, with cancer, and every clinician can tell you about this. And the spouse that's coming in to visit also has cancer, but they aren't getting treatment because they're just trying to help their spouse. They're just trying to get through this with their spouse. And I can't tell you how many times, you know, we'll know that person that's the patient. They'll be in and out, and we'll be taking care of them, relating to the family. And as soon as that person dies, we have their spouse in with the diagnosis. That's just phenomenal, you know. And even if you know the spouse is sick, or if you know they have cancer, they don't want to get treatment. They don't want to talk about it until they finish taking care of this person. So, you know, sometimes we can shift that a bit and get treatment started a little earlier. So it is about looking at the entire story. What is the story of the family? And how do you get the story? You get the story by doing, again, what Dr. Bowen talked about. I think this is a really big challenge. It is for me. And that is to stay objective and neutral. Neutral. Neutral is a wonderful place to be. It feels wonderful. And I know when I am in neutral, I'm like just gliding like ice on ice. But when I'm not, I'm hitting every rock in the ice rink. I'm just...
So as a consultant, you think there's value in trying to be neutral?
Just try to be neutral.
To what effect? I mean, what's the benefit of that?
What being neutral means, but there's a second part to being neutral that's just as important, and that is staying connected to the person, that the person knows she's walking with me, she gets it, she knows what I'm doing, she knows what I'm up against, but she's not messing with me, she's just walking with me. And what she's doing, or what he's doing, is asking really good questions. Time of hospitalization is a time to ask really good questions. Facts are always friendly. That's another Dr. Bowenism that he said many times. Facts are friendly.
What kind of questions do you ask when you consult with someone who's at the hospital and going through, say, a lengthy treatment? When you say good questions,
Well, lengthy or even short, I always start with making a connection to the person and somehow letting them know, I got you covered. You know, we're going to walk through this and we're all right. And then I go for facts. I do a genogram. Again, it takes me 15, 20 minutes. I have the whole picture in front of me, and I keep that as my working tool. And as I learn more information as the patient stays, I shift what I have written on my genogram. What that tells me is many things. For example, who is this person that's in the bed? Because every person in a family is not created equal in terms of their emotional importance. If you have the matriarch or the patriarch who is sick, that is a different person than someone who has less emotional valence for keeping the family organized, for example. Where I have seen that the most clear would be in gypsy families. If the matriarch of the gypsy family is in the hospital, that is very big for that family and for all of us taking care of her. So I look at who is this? Who is this person in light of their entire system? And what balance are they holding for the rest of the system? That tells me something about where things might fall apart a bit, where I could intervene with someone at home. It also tells me something about how the family will do if the person doesn't do well. It tells me something about what may have contributed to this person becoming sick. So I am interested in who is the person that I'm speaking with, who am I with in terms of their family. Then I want to know who's around for them, who's available, who's next in line. I'm looking at what has this family been up against in the last year that may have contributed to this particular hospitalization. What's been going on? Who's graduated college? Who's gone and left home? Who retired? Who died? Who got sick? Who moved? Who lost a job? All of those things over a period, as much as I can get, at least a year.
Okay, so you're the investigator in the room, and you go about asking all these questions. What for? I mean, what you want is the person to get well and go home, and that's that. They don't come to you to change anything for treatment in terms of, family therapy or anything.
No.
So now what? You know all these, and what's your role?
The way that works is it has a clear, direct line to how that person manages their care in terms of speed of healing, less accidents in the hospital, less falls. Falls are a really big problem in the hospital. So we would see less patients falling, less mistakes made. The person is more clear thinking. It's pretty anxiety producing to be in the hospital. One thing we know is the higher one's anxiety, the lower their ability to think clearly. It kind of goes like that. Mm-hmm. So you raise the anxiety and the ability to think goes down. You put in one neutral person who can stay the course with the family but not get into it with them, that anxiety goes down and the thinking goes up. So what I want is this person to know that they're in charge and that they are the smartest person about themselves and their family. Not me, not the surgeon. They know best what is good for them.
So would you say your intervention is sort of lifting the person to the best of their abilities? I mean, given the circumstances they are, that they might not feel well, etc., but you're there to support their best capacity so they can handle the situation at the best possible?
That is absolutely what I want. I want the best possible outcome.
I remember going back to that lecture that you gave, and I was in the audience, that you were saying how one can be in charge of the course of the treatment. And I was thinking, what does she mean? I mean, this is a very complicated medical issue. Sometimes not even the doctors know what to do. Why are they asking, I mean, in that case, the parents of this little child who was in the hospital, why are they asking if they should go with A or B treatment? Didn't make sense to me at that time. But when I heard you saying that it's important for you to be in charge, to ask the questions, and to maybe not make the medical decisions, but ask and be engaged, and don't feel that you have anything to say in the process. That was important.
The goal would be for the patient and his family to be captain of their own ship, using the physician, the surgeon, whoever, whatever person, medical person they have to relate to, as a consultant, an expert consultant to them, a person that gives them the data they need to make a decision, all of the facts, what are the options, what is the whole story here. And one of the things that's really fun and interesting to watch is coaching a person to ask questions of their provider, healthcare provider, that will give them answers. Because you can ask a question of someone and you will get a response, but it may not be the answer. So, you know, I sort of clue them in, like, make sure you got the answer. And to make sure you get the answer, I want them to ask their question as clearly as possible. And I try to coach people, write your questions down. Write them down, because you're going to forget the minute you get in the conversation.
And sometimes the patient thinks that they don't even have the right to ask the questions because the doctors come in such a rush and or the nurses come and they want to give you a pill. Hey, hold on, what are you giving me? This is what you should be taking now.
No.
Well, tell me what it is, even if I don't understand how the medicine might work in terms of
I
physical.
encourage everybody who is alert and oriented to know what is the medication that is appropriate. What is appropriate for them? Who ordered this? And if they can't do it, they're too sick, then I work to identify a family member, friend, who will do that, who will make sure that things are staying on target. The idea of asking good questions and thinking that you have the right to ask the question. Do you know one of the first ones that I start with is, what is your physician's name? Do you know, sometimes people are having surgery and they don't know the name of the person who's operating on them. There are so many people in and out. They cannot necessarily remember if they were told. So let's start with that. Who is the leader of your team medically? You're in charge, you're the captain of the ship, but who is the leader?
I love that analogy. Being the captain of the team doesn't mean that you have to row the whole way. You don't have to know the equipment in the ship. You just have to be there knowing what's going on, and that's a good start.
You want to know how to make the most of what is available to you.
Now, another aspect of it, because you're talking about navigating the medical system, how to have other people support you while you're trying to do that. How other people in the family can support you with the other kids, with or the boss, with whatever you left out in the job. So how to have recruit other people to support you in this process.
Well, one of the things that I do with my genogram is I find out who's out there, who can be counted on, because I have their name right here and I have their relationship. I'm also looking in that genogram to see how cut off a person is. Do they have anybody? And somebody who says, well, you know, I don't have any, my parents are dead, I don't have any siblings, I don't have any relatives. Almost always there is a cousin or somebody, but just that piece of information, I don't have any relatives, gives me a piece of working information. That tells me the baseline anxiety of that person is already higher. And a person who has more of a network, more of a social network, I think they're going to be a little better off. But one of the things I do is I look through the family gathering on paper, then I try to meet them, and I identify one person who's going to be the spokesman. Because it's so busy in the hospital, really you can't have several people calling and asking different questions. It gets all chaotic. So I ask the patient who would they like to be the spokesperson in their family. If they don't come up with somebody, then I do. And that person is in charge of calling the nurse's station, finding out the information, how is so-and-so doing, and relaying it to the rest of the family.
That's an important piece of information because you don't want to obstruct the medical procedures either. And when you have everybody asking or questioning and you know, not following directions, then that might be also a problem. I don't know if that's a problem that you see in hospitals.
It's a very big problem. And again, it's made a little bit more difficult because staff has such a turnover. But I do think it's important for a family to know who is the physician in charge of their care and who is the nurse leader of the unit that they're on. The staff may change from day to day, but the leader is the leader. And if they know who that person is and how to get a hold of her, they just calm down. They mostly don't get a hold of her. They just like to know, here's the person in charge. If I have any questions, this person will help me. And then I work with that staff to tell them about this person. They don't have time to do what I do. And so I give them what information I can, being very careful to only give information to other staff that they need to do their job. So everything someone tells me, I don't tell anybody else. It's just on my little piece of paper. But I do give information that will help the person behind me take better care of this patient.
So as you say, having someone neutral in the team that can connect to the various participants is a help for the person or the family who's going through this process and take charge of their own process. Now, I don't know if in all hospitals they have the luxury of having someone like you.
Most hospitals don't anymore, or they have someone who does a version.
But somebody from the family can be in that role. I'm thinking that probably if there's not a professional there, somebody in the family that is can be in charge, as you say, and be the spokesman and be the
if they know
bridge.
to do that.
Mm-hmm.
Yes, absolutely.
That makes a difference in the outcome of the treatment, I'm sure.
I think the treatment and a huge difference in patient satisfaction. When a patient feels they have been well cared for, and not just physically, but emotionally as well, if they feel as if the staff has understood them and their fears, they are much happier clients.
Tell me an example, a case that you've worked with that you think it was a good match or a good.
Well, I give you one that's a little extreme, and I want you to understand that I knew what I was doing, and this was a little bit of an extreme, but I'm going to tell it to you because it is. Some years ago, this is a long time ago, I was asked to see a woman in her 50s who had a serious infection in her leg, and it was believed medically she needed her leg removed. And so she was balking at that idea. And the staff were doing their best. It was urgent. It wasn't like any day, any minute this has to come off, but it was urgent. The staff asked me to go see her to talk her into getting her leg removed and help make her understand why she had to have her leg off. And I thought, I will gladly go speak with her, but I will not talk her into having her leg removed. I will talk to her about what she thinks about this situation. So I went in and we had a wonderful conversation, and the woman was very clear with me about how frightened out of her wits she was to have her leg taken off, and she couldn't really make a very clear decision. She was just miserable. And I said, well, when you have an important decision to make, what do you do? How do you make it? And who helps you? She said, I go to my kitchen table, I make a pot of tea, and I drink tea, and then I talk to my son, and together we make a decision. I said, well, what would you think of going home and sitting at your kitchen table with your tea and making a decision? But I want you to understand that if you don't have your leg removed, you could die. I don't know, but you could, because this is very serious. But it's also important that you make this decision your way and the best way you can for your good. And you know what works for you. So, can I get an agreement and understanding with you that you would return? Or, again, make contact with your doctor, what you're going to do within 24 hours.
Wow, okay.
So I went out to the nursing unit and said, Mrs. So-and-so is going to be going home probably. They're like, what? You didn't do what you asked us. What we asked you. Well, she did go home, and she did come back. And she did have her leg removed, and her surgery was very uneventful. And she got herself going into rehab, and did everything she needed to do with physical therapy and really did quite a fine job with the rest of her life, as far as I knew.
But she was the captain of her own
She was
ship.
the captain, and she knew I was going to stick with her. And, you know, I had been in that hospital a long time, and so the physicians and the nursing staff knew that I wasn't crazy, you know, that I was doing this for a reason.
Well, I'm sure you sounded really crazy when you went out that room and said, she's going home.
I was pretty nervous about that.
So you have to go through being very clear on what you're standing also in the face of the
Another
team.
one that is old, you don't see this much anymore. It would be, would you please go in and explain to Mrs. So-and-so that she's going to a nursing home?
Wow.
She doesn't know she's going to a nursing home? No. Her family does, or it would be something like her family doesn't want to tell her that she's going to a nursing home. They're planning on just taking her, and she's going to show up there in the nursing home.
Surprise, surprise.
So that used to be fairly common, but not so much anymore. I mean, we've gotten a lot more open.
But
We've gone from giving no information, sometimes to giving too much information, which now is scaring people that way. You know, don't drop a bomb of information and walk out the door.
What I take from these is that the importance of conversations that are meaningful to the person who's going through the procedure and really listening to what they have to say.
I think that's the big part of it is the conversation.
Yes, you're looking at your watch and it's time.
Is it time? The conversation, and I would say people will pick up on who you are as a person. And another thing Dr. Bowen would say, it's not what you know, it's who you are that makes a difference to people. And
well, on that note,
that's a
we're going
good
to
place
close
to
today.
end.
Yes, it's a good place to end. Thank you very much for this conversation, Bea.
Thank you.
And I'd like to remind you that the Bowen Center for the Study of the Family offers the community affordable psychotherapy in both English and Spanish. If you would like more information about our topic or the services at the Bowen Center, please visit the website at www.thebowencenter.org or call 202-965-4400. You will also find the Bowen Center on Facebook, where you can join the discussion about this topic or other topics. Thank you for watching, and I invite you to join me again for another edition of Family Matters. I'm Dr. Mariana Martinez, and your family does matter.